in response to the growing opioid epidemic in the United States. Right now, really just want to talk a little bit about why this is so important and why we're even highlighting some of these programs. By the way, I'm Barbara DiPietro. I'm the Senior Director of Policy for the National Healthcare for the Homeless Council. We've been doing a lot of work around opioid addiction actually for decades, but we are now seeing an emerging epidemic in the United States, and now we're very pleased to see that this is finally a really priority policy agenda item for both the administration as well as Congress and many states and localities. So thinking through why some of this is so important, just a snapshot of what we're seeing here just using some CDC data. We can see that all deaths involving opioids have increased dramatically in the last 15 years. Just in 2014 alone, 47,000 Americans died of an overdose, and that's about 19,000 from prescription painkillers, and about 11,000 people died of heroin overdoses. And amongst those who are using heroin, overdose deaths have tripled since 2010. And so now what we're seeing in the United States is it's become so prevalent that now drug overdose deaths have surpassed car accidents and firearms as the leading cause of injury and death in the United States. This is just a tremendous wake-up call for so many people. I think in healthcare for the homeless, we've been looking at opioid addiction for a long time. The demographics behind this epidemic are changing, and I think that's what's galvanizing a lot of attention to this. One of the things we also need to be conscious of is that it's not just overdose deaths. A lot more non-medical use of prescription drugs come in, as well as increases in heroin overdoses. And so this really has implications for our hospitals and emergency departments as well. As states and localities are changing their laws to restrict prescription opioids, we're seeing a concern that there may be a shift into heroin from that. And so some of the research shows that 4 in 5 new heroin users started out misusing prescription painkillers. So this is one of the things we need to really be conscious of as an unintended consequence of the policy changes we're seeing around limiting opioid prescriptions. So really this is about a lot of different things happening at once, but I'm really excited today to look at how Boston Healthcare for the Homeless is tackling this issue. They've got a great new program, a very harm reduction model. I'd like to introduce our speakers today. Before I do, though, I just want to make sure everyone, when you're looking at your screen, you should see a box for questions and answers below the slides. We will be reserving time at the end of this presentation for discussion and Q&A. So please, as you are listening and you have questions, please type your questions into that box. We'll be collecting those questions and then addressing them at the end. So with further ado, introducing the speakers today from the Boston Healthcare for the Homeless program, I want to introduce Dr. Jessie Gaeta. She's the Chief Medical Officer there who's really been at the lead of this program. Joanne Guarino, who is the chair of the Consumer Advisory Board and a member of their board of directors. And Barry Bach, who's the CEO and really looking at how to bring up this program as well within an HCH model. Joining us from the Boston Public Health Commission is Sarah Mackin, who is the director of the Needle Exchange and Harm Reduction Services and operates as a partner with them in putting together this program called SPOT. And so with that, I will turn it over to Jessie and her team to talk to us a lot more about what they're doing in Boston. So Jessie, take it away.
Thank you, Barbara. We're thrilled to have a chance to present to you some of the design concepts behind this program and also some of the things that we're learning in our early experience having implemented the program. Before I start, I wanted to give a shout out to a couple people. We actually have this webinar streaming in SPOT in the room, so there are a number of participants in there right now, as well as our amazing nursing staff, Kate Orland, Susan Keys, and our harm reduction specialist, Courtney Kenny. So hi, guys. I also wanted to give a shout out to a couple of dads who I know have called into this webinar and want to ask that there's no heckling, Dad. So let me start just with describing to you kind of how this concept initially came about and explaining the need for this kind of programming. And so in Boston, between 2014 and 2015, deaths from opiate overdose increased by more than 50%. You may know already that overdose has become the leading cause of death among Boston Healthcare for the Homeless patients. We know that from a study published in 2013 by Travis Baggett in JAMA Internal Medicine that really showed this shift over the last 15 years since our previous mortality study in the lead cause of death, which was previously HIV and AIDS-related death and has now shifted to become drug overdose. And in fact, 80% of those deaths, opiates, were implicated. And that study, by the way, was really a wake-up call and went a long way to help mobilize addiction services in our program. In addition to those things, Healthcare for the Homeless, our main building, is really located in the epicenter of this crisis in Boston, right at the corner of Massachusetts Avenue and Albany Street in Boston's South End. It's a part of the city where, in which really is like the biggest hot spot for non-fatal and fatal overdose. And I think actually that 15% of the overdoses happening in the whole city are happening within just a couple blocks of our building. And so we are really living this every day. And in fact, overdoses are happening very frequently in our building. And additionally, I think there's some of our patients who were really not engaging very effectively, some who are very high risk with active ongoing drug use, despite a lot of existing addictions programming and treatment available. And so the concept sort of really grew out of desperation when we were trying to kind of figure out how to manage frequent overdoses in our building, even from an operational point of view. You may know if you work in a healthcare or an addiction setting that when an overdose happens in a building, we have sort of a rapid response team that flies in, and for the next 20 to 30 minutes as you resuscitate someone and make sure to get them off to the emergency room, everything sort of comes to a grinding halt. And so with that happening so frequently, I think my very first question was just kind of how to manage that so frequently in a program that has a very busy primary care behavioral health practice, a busy dental clinic, a large medical respite program, and an outpatient pharmacy. But the concept really grew from there to be thinking of, how can we engage this group of people who are so high risk in a new and different way. And I want to just point out, too, that SPOT, which stands for Supportive Place for Observation and Treatment, the SPOT program is really just one part of our response to opiate use disorder and overdose. And it, again, is really just sort of has the aim of supporting and engaging people who are actively using heroin and other drugs. So we really recognize the need to expand access to all types of addiction treatments, as well as housing opportunities and other social determinants of health. But at the same time, we recognize a parallel need to reduce the harms associated with drug use for people who either don't seek, don't want, or can't access treatment currently. So the goals of this small program are the following. So by providing a safe alternative to the street for people who are over-sedated from drug use, we hope to, first of all, reduce the health and societal problems that are associated with drug use, of course, to prevent fatal overdose, and also, just as importantly, to connect people more effectively to addiction treatment and medical care. In terms of the design of the program, I want to first start by explaining what it is and what it isn't. And as there's been quite a bit of media attention on this program, I think one of the things that's been really important for us is to clarify what it is and what it isn't. So what SPOT is a drop-in facility for people who are over-sedated. They're on some continuum of overdose, and they're at a point where they're really not able to walk, not able to talk. They are sedated heavily. It provides medical care in the event that respiratory arrest, cardiac arrest, or overdose occurs. We are a referral resource to addictions treatment, primary care, and mental health services, and at our core, SPOT really is a harm reduction program. What it is not, and this is really important to be clear about, is a supervised injection facility. People are not allowed to inject substances inside the building. That is illegal. SPOT is also not a needle exchange. We have a formidable needle exchange program right next door, which incidentally has been a very close and important partner for us in the development of this program. So I'm excited that you'll get to hear from the director of the needle exchange program in a few minutes. So just to further describe to you sort of the design of the program, I'll start with the physical space. Unfortunately, it's pretty small. The only space that we had available for this program is a dedicated room that was formerly a conference room, actually, that is located on the first floor of our main facility at this one intersection that I described. It's a room that can fit only 8 or 10 maximum medical reclining chairs and the monitoring equipment that's needed. In terms of the services offered, which I explained briefly in the previous slide, but just to reiterate, what we're providing in the room is medical monitoring of sedation, and I'll describe what that looks like in the next slide. Overdose prevention and intervention, harm reduction, education. When possible, we're trying to connect people to primary care, behavioral health services, as well as addiction treatment if they're interested in that. And we are also able to provide peer support and advocacy. In fact, Joanne's going to talk a little bit about that in a few minutes. In terms of the staffing in the room, we are staffing this room at the moment with one registered nurse who specializes in addiction, as well as a harm reduction specialist who is the person really probably mostly responsible for building relationship, providing education, and linking people to treatment and other services when they're interested. We also are lucky to have consumers, peers who are in recovery who offer support on many days, but not all days, and Joanne will describe that in more detail in a minute. And finally, we have kind of in the background a rapid response clinician who is either a physician or nurse practitioner or a physician assistant who is available by phone or by overhead page for immediate consultation to the nurse and the harm reduction specialist and the peer. This is just a quick picture of the room, giving you a sense. It's about twice as big as this, but essentially we have these reclining, what we're used to calling geriatric chairs in the hospital. The feet can flip out and the head can go back quite a bit. We have continuous vital sign machines that are next to each chair and computers on wheels for some of the documentation. We have behind some of the wooden cabinetry there all of our emergency response equipment, as well as Narcan teaching kits and the like. So I mentioned a few minutes ago that we're doing medical monitoring in the room, and so I want to give you a sense of what the clinical guideline for that looks like, but actually before I do that, I'm reminded to, for a minute, just explain how people come in, because I get that question a lot when people are asking about this program. And so I wanted to explain that. How, if someone is sedated, do they actually get into the room? I think the pattern that we're seeing most often is that people are coming into the room, either walking in on their own or coming in with friends or being brought in by friends or by outreach workers from any of our programs in this area at a point where they're still able to walk, usually. Although sometimes they may come in a wheelchair. We've had someone even carried in. But they come in at a point where the drugs that they've taken, which are usually a combination of a cocktail I'll describe in a few minutes, at a point where those haven't yet reached peak effect and people are still able to walk and often talk to us initially. But within a few minutes of coming into the room, 15, 20 minutes, we're seeing these substances reach their peak effect and people are becoming less interactive and often unable to walk and more sedated. And the clinical guideline that we've drafted and that we're using involves essentially continuous monitoring of vital signs. That includes that includes pulse oximetry and blood pressure pulse. It includes assessing the level of sedation using a formal tool called the ANOVA sedation scale that I've listed here, which goes from level S1, completely alert, not sedated, all the way down through S6, which is unable to arouse. So the level of sedation is assessed frequently in the room. Again, there's some parameters for the nurse in the room about when to initiate a rapid response from a clinician. And in this guideline, we also consider the use of supplemental oxygen, even IV fluids in the case of low blood pressures, and naloxone use. And I wanted to say for a minute that we are using naloxone when, or Narcan, really when there is very heavy sedation coupled with hypoxia or low oxygen levels that are actually unresponsive to supplemental oxygen. So we're able to not use Narcan as often as we would in the field, or if we didn't have this monitoring and continuous monitoring and supplemental oxygen available, but just by supporting someone with supplemental oxygen, we're often able to get them through a period of heavy sedation and respiratory depression without having to use Narcan, although occasionally we do still have to use Narcan. In just a minute on the sedation scale, on the right to the right of the slide, most of the folks who are coming in are at an S3. They're drowsy and still responding to verbal stimuli, but quickly progress to S4 and often to S5 and sometimes even to S6. In the S5, one kind of interesting distinction with level 5, someone who's difficult to arouse, is that they may be unarousable except to even deep, painful stimulus, which is still an S5. Some people even go beyond that into an S6, unable to arouse. I wanted to tell you about the utilization of the program, the small room that, again, has just 8 to 10 beds within the first 13 weeks of operating. So this was a week ago. We had, at that point, 856 encounters among 182 unique individuals. So as you can see, there are a number of folks who are coming into the room repeatedly. We are estimating at this point that we are avoiding about a third of the patients, the participants using this room would have otherwise been transported to the emergency department. And in all of those encounters, you might be surprised to see that we've only used naloxone or Narcan 5 times. But again, I think the reason for that is that we are able to do this sort of more in-depth monitoring to actually understand and know what people's oxygen levels are, to use supplemental oxygen, sometimes even IV fluids, and short of having to use Narcan, that kind of supportive care gets people through these periods of overdose syndrome, essentially. I wanted to also just give you a quick sense before I turn it over to Joanne about some of the observations and outcomes that we're seeing in the room. The first one is that the cohort of people using this program are extremely high risk, and you'll get a sense of that from some of the data that Joanne's going to share with you. But the most common scenario that we're seeing is that substance use is layered with a very typical cocktail, as it's called, here on the corner of Mass Ave and Albany Street, that almost uniformly consists of the mixing and layering of 5 different substances. And those are an opioid of any kind, including heroin or pills. And I will also just say that in the midst of this, fentanyl sort of playing a much bigger role in overdose in our part of the area, actually I think most of the supply of heroin at this point is adulterated with fentanyl. That's coupled very often with a benzodiazepine, most commonly Klonopin or clonazepam, as well as clonidine, which is a prescription medication used for hypertension as well as some other psychiatric conditions. We're seeing a lot of clonidine use at very high doses, as well as gabapentin or Neurontin, another prescription medication used for neurologic pain and a number of other indications. And then a fifth medication that I've only learned about in the last year or so being layered with these is a medicine used often to treat nausea, prescription medication called Phenergan. One of the other kind of big kind of things that I've been learning is that the overdose syndromes, as we've started to call them here, that we're seeing in this room are very complex. They are different often from pure opiate overdoses because bradycardia and hypotension are very often out of proportion to the amount of respiratory depression that we're seeing in the people who use this room. So respiratory depression and sedation being kind of the hallmark of an opiate overdose. In this population, we're seeing very slow heart rates or bradycardia and very low blood pressures, hypotension, that I think is probably a result of this combination of clonidine, benzodiazepines, and other sedatives. And then the last thing I'll say about some of the observations I've had in getting this program off the ground is that the relationship that we have with participants in this program, to me, is very different from the relationship that we have in other parts of our program that are more kind of traditionally clinical relationships. And the good example I'll give you about that is that as a primary care doctor and a prescriber, when I see a patient come into my exam room who is sedated, and we talk about that a little, the response that I most often get is the patient will really not be forthcoming necessarily about why they're sedated or about having taken any substances illicitly, but will instead often tell me, I'm so used to hearing, I'm just sleepy, I couldn't sleep last night, I was sleeping on the steps of the church, or sort of talk about how they're just tired, didn't get any sleep last night. But in this room, that conversation has completely shifted, and it took about a week or maybe two before there was really a very different kind of trust and relationship with the nurse and our rapid response team. And now patients come in and say, listen, I'm really glad that you're open. Do you mind if I stay here for the next couple hours? I'm kind of worried about what's going to happen because not only have I taken a half a gram of heroin, but I've also taken 6.1 milligram clonidine pills and 5 Klonopin, and I've added some Neurontin or Johnnies that they're referred to on the street, and I've added some Phenergan, and I'm really worried about what's going to happen. So it's been a really different kind of conversation in the room. Before I turn it over to Joanne, the last thing I want to let you know is about some of the ongoing research that we're in the midst of in terms of this program. The first is public orderliness in our neighborhood, and this really grew out of lots of conversations that Barry will talk about briefly that we had with our community associations here in the South End in Boston. We've been actually, for the past 24 weeks, so 12 weeks before we opened and 12 weeks after we opened SPOT, we've been conducting a survey, a physical survey of the 500 meters surrounding our building, and we've been documenting through standardized observations kind of the burden of drug use in this community based on standardized metrics like the number of publicly discarded syringes and people who are visibly oversedated on the street in public, drug-related litter, those kinds of things. And the results of that are just being tallied right now. We hope to share those with folks in the future. We also are conducting a survey of the community members here, including residents and businesses, on their perspectives, on their knowledge about this overdose crisis, and also their ideas about the kinds of things that might help as a way to try to give the community some voice in this conversation. We are just about to begin, actually we're just designing this right now, a case series so that we can describe the overdose syndrome that I've just explained to you. Probably going to highlight the overdose syndrome across perhaps approximately 20 patients, so we can sort of look at we can sort of draw conclusions in looking at the patterns in vital sign and sedation change over time based on which substances people are using. We also are planning to do a retrospective case control study to determine the impact of this program on ambulance and emergency department use among people who are oversedated. And as a pipe dream and something that we'd have to raise money for, we would really love at this point to have enough resource to conduct a prospective cohort study of people who inject drugs in Boston and who are homeless, so we can look at patterns of use and of patterns of utilization of the addiction in healthcare settings, et cetera, housing status over time among this population. And with that, I'm going to turn it over to my esteemed colleague and boss, Joanne Guarino. And Joanne, before you launch into your discussion of the consumer involvement in this project, I wondered if you could just sort of talk for a minute about what you thought when I initially pitched this idea to you and how that evolved.
Yep. Hi, Barbara. It's Joanne here. Joanne Guarino, how are you?
Good. Thanks so much for joining us on this discussion.
Okay. So I'm going to share a minute about what I thought of this program when I first came around and heard about it. I was totally against it at first, and I thought Jessie was losing her mind, if you want to know the truth, and a few other people in this building. And so I was saying, are they crazy? Like, how are they going to do this? This isn't going to work. Beep-a-ba, beep-a-ba. They need to go into detoxes. That's what we need. You know, we need more of them, et cetera, et cetera, et cetera. And then one day, I don't know what happened to me, but this bell went off in my head. Like, and I share this story a lot because this is exactly how it happened for me, where I realized, oh my God, all these people are dying out here. We can't put dead people in detoxes. It's not going to work. So I realized at that moment that we needed to find something else in between the detox and where people were. We had to go out there and meet them where they're at somehow. And we weren't sure exactly how to do that, but this was a beginning, because as it stood, nobody was doing anything, no place anywhere was doing anything, except all we kept hearing about was people dropping dead, and it wasn't sounding very good. So this was something, you know. I always say if people are breathing, there's hope, you know what I mean? And I try to keep that alive in my head, you know, as long as people are breathing, there's hope. And that's my thought about that. But let me go through these talking points with you. Consumer participation in weekly planning meetings. That's where I was part of. We had meetings like before we even opened the spot. We had these meetings that we kind of gave feedback on how it was going to work, you know, where I didn't agree with certain things and I did agree with certain things, and I'm just blessed that they put me in as a consumer to be a part of this. The second thing is consumers' perspectives sought in survey conducted at needle exchange program before opening. And I'll share those results with you on the survey in a minute. Consumer interviewed harm reduction applicants. Okay, the other thing is consumer presence in the room. And that's kind of what I do. What I do is I sit in the room, and I realize Jessie just explained to you that a lot of people are incoherent for the most part, but not right away. So what I do is I chat with them. I try to build some kind of relationships with them, and so I get them a sandwich if they want one. I make fresh coffee, Dunkin' Donuts, and they like that. And I give them hugs if they need one. I take them to the bathroom if they need to go. I think what I add is the fact that I've been there and I understand, and I understand their pain, like I know their pain. You know, and as my girlfriend always says, there's no greater authority than someone that's lived this life already. So, okay. So the survey. It was unknown if those at greatest risk of OD would use SPOT. We didn't know if they would use it or not. We weren't sure. Okay, so we conducted a cross-sectional survey of consumers who self-identified as injection drug users. Okay, so we did 237 surveys. They were collected at A-Hope, the needle exchange next door. This study evaluated proportion of drug users willing to use the spot, factors associated with willingness to use the spot, and perspectives on the design of spot. Okay, so the survey that we did was we wanted to know if they ever sought treatment. And believe it or not, 95% of them, actually almost 96% did. We wanted to know if they ever used alone, which was a huge risk factor for overdosing when they use alone. And that was 90% of people who have used alone. We asked if they ever had an OD, if they ever overdosed, and like 75.7 of them said they have. That's a lot, percentage. Then we asked if they OD'd within 1 month, which means very recently, and there was 49% of them said yes. We would like to, no, wait a minute, what's that say?
Would like treatment?
Oh yeah, we wanted to know who would like treatment now, and 82% of them said, yeah, they would. That's a good thing. And we asked if they were willing to use the spot, and 93% of them said yes. And so that just allowed us to understand that we needed something. We needed to, we had a need here. We come up with.
Mm-hmm.
So, Jesse, you want to do that?
Sure. And then Joanne just asked me to kind of explain the last question in the survey here, and this is the percentage of people who use the needle exchange program who would be willing to use a supervised injection facility. And even though that's obviously not what we're doing, we were interested to know in this geography whether this was a population of people who would use a supervised injection facility. And interestingly, actually 91% of the 232 people who answered this question would use a supervised injection facility. You can tell. Mm-hmm.
Yeah. Okay, so now I'm going to introduce Barry Bach.
Thank you, Julian. So Barbara and the council, thank you for having us do this talk, and we're really glad that there's so many people on the webinar today who are interested in this topic. It's something obviously that's near and dear to us. Jesse asked me to just mention, before I jump into my talk, the hours of the spot. And the hours of the spot were really determined by looking at what were the height of the overdoses in the epicenter of the crisis, which is where we're located on Mass Ave in Albany. And believe it or not, that tended to be between the hours of about 8 a.m. or 8:30 a.m. and 2 p.m. And a lot of that was because there are a number of shelters in our immediate vicinity as well. In fact, there are now 700 shelters within 2 blocks of where we are, and 1,100 shelter beds within 10 blocks. And so as people were leaving shelter and using for the first time in the day, that was often the time that we were seeing the overdose, and often right before someone was going in back to shelter. So just by way of background. Yeah, so right now it's a daytime program, open 8:30 to 5, and it will soon be open essentially from 8 a.m. to 8 p.m. just because we're seeing a greater need as we often will have, when we've had to do the ED transfers, that's often as we're winding down for the day. So we're hoping to be able to avert that and make it a more comfortable stay for folks if we're open till 8. So my responsibility now is to just share a little bit about the community engagement and some of the financing. And because the South End, especially in the past 15 years or so, has really become incredibly gentrified, we are surrounded not only by shelters and a lot of businesses. We're across the street from a really phenomenal academic medical center, the Boston Medical Center, but we're also surrounded by literally million-dollar condos. So because this is such a, it's frankly incredibly obvious what's going on in the community. When you look right across the street from our building, you'll sometimes see 40 or 50 people congregating. There was a lot of community interest. We did this really badly. So just to say that at the outset. So Jesse and I had started to meet with the community. We had started to have conversations with the mayor's office. And then we made this major faux pas, so don't make this faux pas, guys. Jesse, yeah, so this is actually Jesse's fault, I'm realizing as I'm saying this, is that Jesse did a piece on National Public Radio that was picked up nationally, and about the SPOT program before we opened it, and it really put a lot of our state officials and city officials in a really awkward position because they were having to respond to something that they didn't really have the background on. So Jesse and I were actually called into the governor's office, the mayor's office. We met with all of the city councilors, and we were having to do this from a cleanup perspective rather than, I wish that we had gone to them all first before we had done the NPR piece. But as I mentioned, the South End is a pretty vibrant community. It's really become more vibrant over these past 20 years or so. And so just in our small section of Boston, there are 9 community groups, and they're all incredibly active. And so Jesse and I met, and this literally was close to 40 meetings when you think about the governor's staff, the mayor's staff, the city council, and all of the community meetings we attended. But what we found is that the neighborhood associations, our neighbors, were incredibly engaged. And in the end, and we actually had consensus on this, we have 100% support from the governor, from the neighborhood agencies, and from the mayor's staff and the mayor himself. And the issues are issues that we would all agree are reasonable. Frankly, first and foremost, our neighbors didn't want patients dying, and our neighbors were seeing patients overdose and then on occasion dying. And they were really worried also about, sort of the most dramatic testimony at every single meeting was, a young parent talking about that I can't let my kids play in the park any longer because there are syringes that are being discarded, and they're feeling really overwhelmed by it. The piece that caught us off guard that was really fascinating is the community really was hoping that this was not just the SPOT, but they actually were hoping we were going to be opening a safe injection facility. They thought that that's really what the city of Boston needed, and they were, they understood the position we needed to take. It's illegal in the United States, but there was a real push for it. It was, we found that actually pretty fascinating. So this actually is a pretty inexpensive program when it comes down to it. It's around $180,000 a year. As Jesse mentioned, it's just 8 chairs right now, and the room really doesn't tolerate much more than that. And there's a full-time nurse, and there's a full-time harm reduction specialist, and then we have some assorted other expenses where we're helping transport people to detox or to other programs, and we do provide food the entire time we're open. But altogether, we figure the budget will run us somewhere between $180,000 and $250,000, and it really was feeling like a true crisis, and still does in the city of Boston. And so Jesse and I went to Joanne and other board members and said that we thought this was worth even bringing our budget into the red because we were really, we were feeling desperate. We didn't think it would do that. We thought that this was something that was really garnering the attention of the community and sort of millennials in a way that was very different for us in terms of who we've reached out to before for philanthropic support. And as it turned out, we ended up getting a grant through the Blue Cross Blue Shield Foundation, which we're incredibly grateful for, that helped underwrite this. And then we did receive a significant amount of philanthropic support that completely underwrites this for the first year. What we realized, and I think that as Jesse was pitching this to us, we really weren't sure that this would sort of rise to the level where that these would be billable encounters. And as it turns out, that we think that there's a significant amount of the interventions that are going on by the staff in the room that really are billable. We haven't started doing the billing yet, but we will, and we'll be looking at it right now in a fee-for-service model. What's fascinating, and I think as we move towards global payment strategies, and as you think about ACOs, one of the things that we're really struck by is we believe that the over 800 encounters that we've had, about a third of those folks would have ended up in the ED. So you're talking about either 911 transport or some other type of emergency medical service transport, as well as an ER visit. So I think that there's some really significant cost savings here. And frankly, it's a much more comfortable environment for people to be in. And then finally, this isn't a benign program. And because of the kind of community tension that existed, because of the attention of the governor's staff, the mayor's staff, we wanted to make sure we were really dotting the I's carefully and doing this the right way. And so very early on, after this concept was pitched, we went to the Department of Public Health, which is the licensing agency in Massachusetts, and we expressed to them that we saw this as just an extension of our present clinic services. So as Jesse mentioned, it's just down the hall from our largest ambulatory clinic that we run at Healthcare for the Homeless in Boston. And we just saw this as an extension of that. We then, sent in the appropriate paperwork to the Department of Public Health, and also sent in with them the clinical guidelines, and it was well received, and they viewed it as exactly that it was nothing more than just an extension of our clinic practice, and there's nothing in the clinical regs or the clinic regs in Massachusetts that precludes observing patients for extended periods of time or starting an IV. So it actually just fit neatly, and frankly, once the DPH, which is the regulatory body, once that was resolved, that then also opens the door for us to do, to be able to bill. And then just sort of reiterating some of the lessons, it's so important to talk to the community before engaging the media. I can't tell you how many times we've cleaned up from that faux pas. One of the big issues, I should say, that the community begged us to do is not to have this become a drop-off center for the police. They did not want the South End being a magnet for other parts. Boston's made up of a number of communities. They wanted us to be really careful about not having patients brought in from all over the city. And frankly, the need is so great in our immediate community. We really felt like we couldn't tolerate that, and so we do respect that. I think it's a little bit frustrating for the police department because we are a resource for the police department as well. And again, the community has really been wonderful. It's I would say we had an okay relationship with our community partners over the years, but this really strengthened it. It really opened sometimes pretty intense dialogue, but it's been incredibly helpful. And we're now seen as part of the solution rather than as part of the problem, which is, I think, how it was early on. And then, the last bullet point here about controlling messaging, I think because the media was feeling fairly desperate about looking for what is next, what can we do, how, what are sort of the things that we can, that's happening to address this crisis, they were looking, I think, and I don't mean this in a negative way, but they were looking to be more provocative than we were trying to be, and they kept trying to paint us as a SIF, as a safe injection facility. And so we constantly had to be on guard for that and be much tighter about our messaging than we typically are. So let me stop there and turn it over to Sarah Mackin, the director of AHOPE.
Thanks, Barry. I also want to be cognizant of time. I know that we're running up on the end of the webinar, so good thing I'm pretty famous for my speed talking abilities. We'll go through some of these slides. I think AHOPE's primary role was a little bit more on the technical assistance side. Just to give you guys a little bit of background on AHOPE, it was the first needle exchange in the state, opened around 1993. We were also the first Narcan pilot site in Massachusetts, so we were the first community-based organization to do bystander trainings on how to recognize the signs and symptoms of overdose, and also be able to enroll active users, active drug users in Narcan and have them carry the medication. We serve about 5,000 to 7,000 people a year. That's individuals. We have a fixed site, and we also have several mobile sites throughout the city of Boston, but our busiest site is our fixed site here on Mass Ave in Albany. Our syringe return rate is around 106%, and that's because we're fortunate enough to have pharmacy access in Massachusetts. So we have a Sharps team, a mobile Sharps team that works in conjunction with the Mayor's Health Line, so that if a community member sees a discarded syringe on the street, they can call it in and give them the location through a smartphone app, and the team will respond in real time to pick up that syringe. So that's a really valuable service that we're able to provide to the entire city of Boston. AHOPE is not just a needle exchange program. I think I would say, we sort of need to rebrand ourselves as a drug user health organization as opposed to just a needle exchange. We offer everything from detox placements, residential programs, getting people into outpatient hepatitis C treatment, case management, and medication-assisted treatment, methadone, Vivitrol, Suboxone. And Healthcare for the Homeless is not only sort of close to us in proximity, we're connected to the building. It's very close in terms of like philosophically the approach that they take with this kind of large shared patient population that we have with them, the folks in this area. Today we've had about almost 1,000 reversals reported just for this past fiscal year of 16. So that's 1,000 times that our participants have used Narcan to reverse an overdose and save a life, which we're pretty proud of. Our participants are pretty amazing. And we've had probably close to about 600 substance use treatment placements, really is a better word than just referrals, because it was sort of intensively, we walk people over, make sure they get that bed, and we're also proud of that, that we're able to offer folks access to treatment when and if they want it. Just to give a little bit of background in terms of, like AHOPE, just like all other needle exchanges and a lot of social service agencies in the area, continually monitor oversedated folks. And we've been doing that for years, but the tools that we have are really limited. And in Boston, the fact that we have this sort of culture of polysubstance use with everything from Phenergan, which we call Finnegans, which I think the docs always laugh at me when I call them Finnegans, benzos, clonidines, on top of opiates, it becomes a very complex sort of like medical situation that we are increasingly seeing. Someone comes in, they're oversedated, we really don't necessarily know everything that they have on board, and all we really have is physical stimulus like sternal rubs, and just basically just monitoring this person, watching them breathe, and then sort of deciding when to intervene and administer Narcan. And unlike Healthcare for the Homeless, we actually do not have the ability to continually to monitor someone after we've administered Narcan because of the state guidelines around the Narcan pilot. We are required to call 911 every time we use Narcan on the individual. So that individual usually ends up in the emergency room. So just very quickly, and this is probably going to be old hat to a lot of folks who are harm reduction folks on the call today, but just an idea of like what does harm reduction look like? And again, I think that Healthcare for the Homeless is a natural partner for AHOPE and all other harm reduction programs because just philosophically they understand low threshold programming. Very basically, we call it the 3 A's. Anonymity, there's some sort of expectation that participants can have that they don't have to give their name, they don't have to give identification. Make sure that the services that you have are accessible to folks, and that can mean anything from like making sure that they don't have to check in with security before coming in, or just making sure that you're soliciting consumer input to make sure that the hours that you're open are actually the hours that people are going to need those services, and the attitudes of staff, which Healthcare for the Homeless already has sort of down pat. Engaging people in a respectful, non-judgmental, and participant-centered manner. So what our medical folks will call patients, we call them participants for folks that aren't familiar with that terminology. And really all this is about just acknowledging and accepting the fact that drug use is a central part of the folks that we serve, their lives, and whether we like it or not. And so abstinence shouldn't be a prerequisite for giving medical care or any other services for that matter. All right. Sorry. I'm going to hand it back to you, Barbara. I'm sorry, I thought I had one more slide, and I clearly don't, which is good.
But thank you all. That's been really interesting. I know a lot of people have been trying to get more harm reduction models in their community. We've had a number of questions come in, so we've got 10 minutes left, and let's just maybe plunge in. A couple of them are health center related. So one question I'll just start with Is the program covered in your HRSA-approved scope and covered by FTCA? I'm sorry, Federal Tort Claims Act.
Go ahead, Barbara. There.
Yes, we talked to our federal project officer about it before we implemented it, and yes, it was covered under the scope.
And then I think you had said what your hours of operation were, but can you repeat them? We had a couple of questions about your hours.
Sure. We're open at the moment Monday through Friday from 8:30 in the morning until 5 p.m. We're within a couple weeks we're going to be extending later into the evening that we've noticed a need for. So we'll essentially be open 8 a.m. to 8 p.m. Monday through Friday.
Got it. And then there were a couple questions about you had indicated there were 8 chairs and you had limited capacity. So what happens when you are full and you have additional people present? What's your protocol at that point?
That's a really good question. That's something we've been kind of troubleshooting, and we've found that Barry mentioned that this room is really part of our larger outpatient clinic on site here. And so what we've been able to do is when we have enough staffing, nursing staffing primarily in the clinic, when we have people come in who are kind of overflow and who need medical monitoring, we're able to set up one of the exam rooms when we have enough nurses on hand to do this for another small number of people in the clinic itself. But beyond that, or when that's not available, if someone needs medical monitoring, at this point they would have to go to the emergency room, so we transport people to the ER if we're beyond capacity and have no additional space and staffing available in our outpatient clinic.
There were a couple of questions about demographics, and so curious if you're collecting any data about whether people, when they present, are they staying on the street, are they staying in shelters or in housing, supportive housing or other housing situations? Just a little curious about the background of folks coming in.
That's a good question as well. Everyone that we've served so far is currently homeless. Most of the folks are staying in one of the 1,100 beds at night that Barry alluded to that are within a short distance from our building. A number of the folks that we're getting to know well in the SPOT program are street dwellers who are sleeping outside at night. We haven't seen anyone yet who has been housed.
There were a number of questions that came in that had to do with how people are connecting to treatment. And I know, Sarah, you talked a bit about the services that your program offers. Certainly, Suboxone treatment is in the HCH program. But given the number of people who said that they were ready for treatment, are you tracking any entry into treatment or outcomes or follow-up, or what does that process look like for you?
Mm-hmm. Yes, we are tracking. We are trying to track when we make referrals from the room into treatment. And by treatment, I mean that very broadly, to say that whether that's medication-assisted treatment, either methadone or buprenorphine, or other treatments like detox and then residential inpatient treatment, for instance. So we're tracking how many referrals we're doing. One thing that's hard about that is that a lot of folks may not, who are interested in treatment, may not be wanting to go in when they're at SPOT or directly from SPOT. But because of the close partnership we have with AHOPE next door and some of the other programs of the Boston Public Health Commission, the addictions programming, we are aware that a number of the folks who've used this program have gone into treatment within a couple days even of using SPOT. And that's something that's harder to track because it lives outside of our program. But in general, what I would say about how many participants are going into treatment, it's a relatively low percentage of people. And I just to sort of remind folks that this is a population of people who generally have been through multiple episodes of treatment and have had multiple relapses, and it's a group with very severe substance use disorder. And so going into it, my hypothesis was that it would be a small number of this particular group who entered treatment any one day. And that has proven to be the case. I think my hope is that over time, with repeated encounters and relationship building with folks, that we can help encourage people into treatment. But at this point, I would say that it's less than 10% of people who are who have accessed treatment in the 13 weeks that we've been open.
A couple of questions about your police relationships, and this is in follow-up to some of Barry's comments. Can you say a little bit more about the police or the police frustration, or how you're a resource for them, or how this may have affected your relationship with them, your pre-existing relationship with them?
So I think the Boston police are like a lot of the police around the country on this, that that historically they viewed the actions as criminal, and now they're buying more into the harm reduction model. I think it's pretty. There are a couple cities in Massachusetts, in Arlington and Gloucester, where the police chiefs have really taken on some interesting initiatives, trying to get people into care rather than trying to make arrests. And Boston police are the same in that way, and so I think that they're frustrated. They're frustrated in seeing the deaths. They're frustrated in having to administer Narcan, and so the Boston police have been very receptive to this concept, but frankly also a little disappointed that they can't access us as much as they would like, because this is an issue that's greater than just the epicenter where we're located, and we frankly don't have enough beds, and we also have commitment to our neighborhood associations that we won't grow it. So I think the relationship is generally fairly positive, though I think we do leave the police department feeling kind of frustrated. Would you say that's accurate?
Mm-hmm.
Yeah.
Mm-hmm.
One thing that we got a question about, are the users of SPOT already healthcare for the homeless patients, or do you find that this may be your first encounter with them?
Mm-hmm. There are more patients that we have never seen before than I expected, and so I would say the answer is yes and yes. There are patients who we have historically seen but not necessarily been well engaged with, and this program has enabled us to be much stronger, to have a much stronger connection with them, and has sort of shifted our relationship with them quite a bit. And at the same time, and I haven't actually quantified this yet to be able to tell you what percentage, but we're also seeing many people who we've never seen before and who are not connected to healthcare services, at least, at all. And I'm really happy about both of those things.
That's really great. I'm curious to ask Joanne a question. Joanne, you had talked about your own changing attitude as a result of your work with this program. Would you say that other consumers that you work with have also had similar thoughts going into it, and you've seen another change, or what's your observation of other consumers' attitudes for this?
Yeah, well, some are a lot like me, but a lot of them are still on the fence with it. I think, I did this for a lot of years, like 30-something years, so my way of thinking is old thinking, and I find that a lot of people that are either on the cab with me or just people that I know kind of still feel that they need to be in detoxes and this is not working. But I've been trying to explain to them, exactly what I have explained to you guys, that what's happening is now, I watched the first time I watched somebody, Barry actually, save somebody's life with Narcan, and I never seen that before, and that really turned my way of thinking. So now I can explain to others like what I've been seeing. So the way that I was thinking before and the way I'm thinking now, I kind of share. There are some people on the fence, but they'll get it when they get it, if they get it at all. I mean, I can't make everyone get it, but it'd be nice if everyone would.
Thank you. We're at our time. I just want to thank all of you for sharing your expertise this afternoon and talking about this program. You guys are taking bold moves in Boston. Everyone's looking for something that they might be able to do. So this is a really great discussion, one I'm hoping that we can continue. Want to let folks know that we have another upcoming webinar at the National Healthcare for the Homeless Council in a couple of weeks. This complements a policy brief that we've just put out, specifically focusing on the use of buprenorphine in homeless populations. So if this is of interest, please register. Also want to reiterate for everyone that the recording of this webinar and the slides will be posted to the site and will be emailed to you if you registered within a few business days. Just get us a few days to clean it up and post it. So you will get that. And again, just really want to express our interest in you coming out today, and thank you to all of you in Boston for coming in and talking with us. So much appreciated.
Thank you, Barbara.
Thanks, Bob.
Thanks, everyone.
Thank you. And at this point, we will close the webinar. Thank you, everybody, for coming, and have a good day.